Hello everyone, welcome back to the channel. So in today's video we'll be tackling cardiovascular disease. I know it is a huge topic and then we'll have to study only the most important things because I don't want you to get confused with all the terminologies and all the investigation and the diagnosis. So this video only the high yield stuff that AMC asks, and we'll begin with for the diagnosis of abdominal aortic aneurysm. You have to think like painless pulsatile abdominal mass in an elderly male smoker. And then if it is a ruptured AAA, then we'll have to think about severe abdominal pain that is radiating to the back and hypotension and pulsatile mass. This is a deadly triad and you'll have to call the surgeon as soon as possible. Now, starting with the initial investigation and the investigation of choice, that is ultrasound, and we'll have to see that the mass that is visible, that is more than 3 centimeter. And for the pre-intervention planning, we'll have to do CT angio. Now for the surgical repair, what are the indications? So in males it has to be more than 5.5, in females it has to be more than 5 centimeter, and then the growth should be more than 1 centimeter. Then for the surveillance of abdominal aortic aneurysm, there are two different tables that we are following. One is of 2010 and the other one is of 2017. So we'll have to remember this because AMC asks about it. They'll mention you the centimeter, the size of the aneurysm, and then they'll ask in what period we'll have to do the surveillance. Now coming to the family history of abdominal aortic aneurysm. So what are the screening indications? So if the patient's family is having a family history, then we have to screen after 50, and if there is no family history, then in males it is more than 65 and in females it is more than 70. Now when we are talking about the risk of rupture, so these are the percentages according to the centimeters. So if it is more than 3%, then there is 0% risk. Likewise, we'll have to remember this table because rupture risk they can ask, because it is kind of important. Now coming to the treatment. So if the patient is asymptomatic, then surveillance and elective repair is what we are doing, and the patient is symptomatic, then we'll have to go with immediate vascular surgery, and this is like the definitive treatment for it, and we'll have to do surgery only. The next topic is acute pulmonary edema. It is a very important topic, and then the whole pathophysiology you must be knowing. You have seen multiple videos, you have studied it in your college also. I'll only focus on the main things. So we'll have to start with oxygen, that is 10 to 15 liters per minute via Hudson mask or reservoir bag. And then we'll have to correct circulation. So we'll have to give the patient IV access. Then we'll have to ask the patient to be sitting in this particular position. Then nitrates we'll have to give, and CPAP if the oxygen saturation is less than 92%. Then this is important, yes. So we'll have to select IV furosemide. We don't have to select oral furosemide. It is from eMedicine. And then last is morphine, that is for pain control. Now what are the important investigations? So we'll have to do ECG, we'll have to do cardiac troponin test, BNP levels, and X-rays. So this is all about acute pulmonary edema. Then we have aortic dissection. So for aortic dissection, in a chest X-ray, you'll be seeing an more than 8 centimeter aortic knuckle. And then for the diagnosis, if the patient is unstable, then we have to do transthoracic echo, and then if the patient is stable, then we'll have to do CT angio. And it is a rule out approach. Now there are 3 different types of aortic dissection. I remember it with the order 2, 1, 3. So 2 is only the initial part is dissected. First one is both the parts are dissected, and the third one is only the distal part is dissected. So this is important to remember it in this order because the treatment would be easily tackled by that. So in 2 and 1, the treatment is surgery, and the third one is conservative treatment. Now for the ruling in approach, we'll have to do urgent transesophageal echocardiograph. This is for ruling in, and then for the treatment, we'll have to give alpha blockers and then beta blockers. This is a conservative therapy, and then definitive therapy we know that we'll have to do a surgery for it. That's it for this. Then we have ACLS protocol. There is a very simple thing that I've written here. First thing, CPR, oxygen, and then we have to attach the defibrillator. Then we'll have to assess if there's a shockable rhythm or non-shockable rhythm. We know like VT and VF, we have to do 2 shocks, then epinephrine, then 1 shock, then amiodarone, and then we'll have to repeat this loop. For asystole or pulseless electrical activity that is absent, in that we'll have to do epinephrine, then CPR, then epinephrine. So this cycle we'll repeat, and then the ultimate goal is to have return of spontaneous circulation. This is it for the ACLS protocol. They can ask you about the patient has already been given one shock in VFVT, what is the next step? So likewise. Now for the cardiac tamponade, I want you to remember that initial is chest X-ray, the gold standard is transthoracic echocardiogram, and the treatment is pericardiocentesis, and Beck's triad everyone knows. Now next thing is, this is a pharmacological table. I have taken all the information from eMedicine and all the question stems, and then you just need to focus on this. So a patient with hypertension, the first is monotherapy, ACE inhibitors or ARBs is preferred, and if the patient is having diabetes, HF, post-MI, elderly, so these are the medications that you need to follow accordingly. And then pregnancy is new mom loves hugs, that is nifedipine, methyldopa, labetalol and nitrazine. Then we have congenital heart disease. If it is right to left, then all the cyanotic diseases would be there, and the name of the diseases would start from all the T's, like truncus arteriosus, transposition of great arterioles, likewise. And then if the congenital heart disease is left to right shunt, then all the acyanotic diseases would be there, all starting with 3 letters, that is ASD, BSD, likewise. Now we have next topic, that is carotid artery stenosis. So this is important, that definitive treatment for this is carotid endarterectomy. And then what are the indications? So the person should be symptomatic with more than 50% stenosis and asymptomatic with more than 70% stenosis. Now for the diagnosis, carotid artery duplex is the initial thing, then confirmatory is MR angiogram or CT angio, and the gold standard is digital subtraction angiography. Then for the symptoms, yes, this is important, that the patient needs to have TIA symptoms or minor stroke symptoms. Now what are the contraindications to surgery? If there is 100% occlusion, if the patient is unfit for surgery, or if the patient is having severe neuropathic deficits. Next is chronic venous insufficiency. For the diagnosis, we'll have to do venous duplex ultrasound, and this SEEP criteria is very much important. You'll need to see the photos of it. They can ask you about what SEEP grading is this, and then what is the treatment accordingly. So initial management is compression bandage, and for C4 and C6 the skin changes would be there. So for that, venous ablation, sclerotherapy or open surgery is the treatment. Now this is important, in pregnancy only compression we are giving, and in peripheral artery disease no compression is given. So this is important. You'll have to focus on the question stem, what is asked. Now innocent murmurs, 7 S's. I have written all the 7 S's here. You have to remember all these things, and then you'll be able to make the diagnosis out of it. So next one is VSD. So these two important things are there in eMedicine also. They have asked this in AMEDEX also. So if there is a small VSD, then the complication is infective endocarditis, and if the VSD is large, then right heart failure, you'll have to remember. Now for digoxin, I've written what are the indications of digiband, and then what are the different ECG findings you'll be able to see, and then what is the indication for IV digoxin or oral digoxin. So that's it for digoxin. You just need to see this and you'll be sorted for it. Now most important topics, most high yield topic, that is DVT. So investigation, first is D-dimer. If it is negative, then it is ruled out. If it is positive, then we'll have to do venous compression. If it is positive, then DVT is confirmed, and if it is negative, then we'll have to do venography using CT or MRI. Then what is the goal of DVT? So we'll have to prevent pulmonary embolism or further clot formation. This is the goal of our treatment. Now we have different scenarios for it, and one important thing, that Human sign and Moses sign would be seen in patient. Now if the patient is having isolated DVT, that means the patient is without risk factors. So what are the risk factors? The patient is positive D-dimer and the clot is proximal to the leg veins. So if these features are present, that means the patient is not at risk. So for that, we'll have to do expected management, that is serial venous ultrasound for 2 weeks, and if the DVT is still persistent, then oral anticoagulants will have to start. Now if we are talking about proximal or recurrent or past DVT presence, then first thing is low molecular weight heparin. Then we'll have to do, if there is heparin induced thrombocytopenia, then fondaparinux we'll have to choose. Otherwise, for renal failure, obese or high bleeding risk, then unfractionated heparin we'll have to choose. For the long-term anticoagulants, first is DOAC, that is 10A2A inhibitors, that is rivaroxaban or apixaban, and then second line is warfarin. So warfarin is we can give in the patients with renal failure, and DOAC we cannot give in the patients with renal failure. Now for pregnant women, as we know that warfarin is teratogenic, so that's why we'll choose low molecular weight heparin over it. and we'll have to switch it to unfractionated heparin 1 month before the delivery, because we can reverse its effect using protamine sulfate. Then APTT monitoring is important, and IVC filters indication I have mentioned. And then yes, for the restart of anticoagulants after vaginal delivery, 4 to 6 hours we can restart, and after C-section 6 to 12 hours we can restart. Both the drugs warfarin and heparin are safe to give in breastfeeding women. So for this video we have just covered 10 high yield cardio topics that AMC loves to throw at you. If you found this video helpful, drop a like, subscribe and comment down below what topics you want me to cover next. And helping you study smart, not harder. It is the basic necessity for you to clear AMC. That's it for this video. Until next time, goodbye.